Welcome everybody to this Homeless Health webinar. If you're just joining, do please keep your microphones on mute and cameras off. We'll start in just a few minutes and give those who are still joining a moment to come in. Today we're going to be looking at mitigating the impact of this Delta wave and variant on our population. So thanks to everybody who has joined today on this hot sunny day and taken the time to come and listen to our speakers, who are going to give you the real in-touch news on how we're going to protect and safeguard this population. So there will be a Q&A bit at the end. What we've tried to do is focus in on the big issues, the big questions that people had for us. But I'll welcome everybody now. So I'm going to welcome you to the webinar. My name is Gemma Gilbert. I am a Director of Transformation in Healthy London Partnerships. And today we've got a series of speakers for you who are going to run through what we're likely to see happen in this next wave, what changes and thoughts have we had about the infection control guidelines, and what support can you be looking to in terms of guidance for what you should be doing in different settings. We're also going to be hearing from Mungos, who are going to talk to us about what they are, as an organisation, are doing as one of the provider arms for this sector. And we're going to be hearing from our local government representatives as well, just so that we get a really rounded picture of how everyone is thinking about the new wave and what action we can be taking to mitigate it. So thank you for joining. The first thing I'll just say is that I hope it's not too disruptive with people joining, and I hope you get a chance to really hear the speakers. But we are recording this too. So this is a conversation and a webinar that you can share through your networks, and we'd love you to share it as widely as possible in order that we help communicate the key messages coming out of this webinar. As we go into this wave and this stage 4 of COVID for the country, I know that many people are very anxious about the lifting of lockdown measures, not least for this particular population. And quite rightly so, but we have lots of things we can do. So there are lots of actions we can take, but it is going to require rapid action and urgent action to really look at how we can protect and safeguard the population. So I'm not going to talk any more than that, other than to introduce our speakers. So today we've got Professor Andrew Hayward, who I describe as my crystal ball, because he always brings a sense of what's going to happen, and has been working closely with SAGE as an advisor, and he's always right. So I trust every word he says. We've got Professor Al Story from the Find and Treat Service and clinical lead there, and also academic, and he'll be talking particularly about the nature of this virus and the respiratory aspects and what we can do to protect people. We've got Sarah Cador from Public Health England. We've got the London response cell, the PHE London cell on here. We've got Mungo's colleagues, as I said at the start, and we've also got Natasha with us from the Borough of Westminster and the Royal Borough of Kensington and Chelsea, and Vicky from Westminster City Council. So thank you, speakers. Welcome to all of you. We're going to go straight into the first presentation, which is Professor Andrew Hayward, to give us that crystal ball look at what's going to be happening as we go through this particular wave. Andrew, over to you.
Obviously, today's a big day. People are calling it Freedom Day, but I think it's still a day for us to be very cautious, not just in the homeless sector, but across the population as a whole. I think one of the only reason that we've been able to get to this day at all, next slide please, is because of this wall of immunity that's been built up across the population. And you know, the vaccines have been incredible, if you like, better than we could ever have really hoped. And across the population, we have very high vaccine uptake rates. But as you'll see in Al's presentation, that's not the case across the whole population. And indeed, we're struggling to get high vaccine uptake rates in the homeless. Next slide, please. But what this sort of wall of immunity has done is it's really changed the nature of the pandemic, such that If you look at this top line, the green is the number of COVID cases in the population over time, and the orange and red are the number of hospitalizations, with the red being hospitalizations in intensive care. And we can see that, you know, this wave around, we have a much less pronounced relationship between the infections that are going on in the population and the number of hospitalizations and deaths. And that's entirely down to the vaccination. But, next slide, please. There's still a huge amount of uncertainty about what happens next. And that uncertainty is largely based on, well, first of all, some remaining uncertainty about exactly how effective the vaccine is. And so even if it's 5% better than we think it is, or 5% worse than we think it is, that could make a dramatic change on our predictions of what will happen next. But these are essentially models that SAGE have been looking at about what happens when we unlock. And if we look at right in the middle, what we're looking at is the number of hospital admissions. And the red line is the number of hospital admissions that we might expect if everybody kind of stays calm, doesn't rush out and change their behavior sort of back to pre-pandemic levels. But we can see that even with that, the number of hospitalizations that we might get could get very high. The dotted line is where they got to in the last wave in the winter. So even if people are still quite careful, it could get to those sorts of levels. If in the black line we went back to sort of pre-pandemic mixing, then we could have a very big wave of infection with levels of hospitalization certainly exceeding what we've had before, and levels of death approaching what we've had before. So despite the fact that the vaccine is effective, if we have a massive wave of infection, which it very much looks like we're on our way to having, well, it's underway already, then there still will be this problem. Next slide, please. And I think that is particularly acute in the homeless population, because as I say, the protective wall of immunity that we've got in other populations has massive holes in it. So so we still have a very big risk of outbreaks and of people ending up in hospital or dying in the homeless context. Next slide, please. And again, you may have seen this slide before, but it's just to bring home comparing across the population from the richest to the poorest areas affects your risk of having chronic diseases. But homeless people are much more likely to have the sorts of chronic diseases that put them at high risk of COVID-related mortality. Next, please. And then this again, you know, you'll be familiar with all of this, but it's just reminding us, you know, the main thing that's gone in the national guidance is the issue about the sort of 1 meter rule. But there's a very good reason for the 1 meter rule, is because, you know, when you step inside that zone, then you're really exposing yourself to high concentrations of exhaled particles and high risk of infection. And of course, infection can spread more distantly through airborne spread as well. And so that's also important. But this relaxation of social distancing is a big thing that's going to drive transmission across the population. And if we lift it within homeless hostels, also very dramatically within those settings. Next slide, please. And then this again is just to remind you that, you know, if you can't socially distance, then masks will help, but they're not, you know, they're not a magic bullet. They reduce the risk of that transmission. They certainly don't remove it by any means. But we should still be recommending masks when we're around other people. Next slide, please. And then this is, again, this is just a graphic that illustrates when you do bring people together into indoor spaces for catering or or whatever, then you can get these sort of super spreader events where one person can infect large numbers of people. And you know, if all of the people in this restaurant are fully vaccinated, then I'm not so worried. But when they're not, this remains of big concern. Next slide, please. And of course, some of the things that are still important to do to mitigate that risk is ventilation, whether it be mechanical or opening windows, etc., will make a difference to transmission. But none of these things remove the risk of transmission. Next slide, please. So this is just really, again, highlighting, we did some modeling after the first wave of the pandemic to show what the homeless sector response had achieved in terms of saving lives and hospitalizations. And we could see even over just the first wave that the response had saved hundreds of lives and probably thousands of hospitalizations. And if you add that up across both waves, that will be an even greater saving. And if you compare that to countries that didn't have this sort of approach and continued to have night shelter type accommodation with shared bedrooms, etc. So, for example, this was a study in France after the first wave. We were seeing about 50% of the homeless population in night shelters being infected just in the first wave. And we had way lower levels than that. So they did an amazing job in terms of preventing infection amongst people experiencing homelessness in the first wave. And, you know, what I'm basically saying at the moment, we're heading into probably the biggest wave of infection that we've ever achieved. We've got high levels of unvaccinated populations. And so we really shouldn't be changing anything. If it works, don't change it. Vaccination works, single room accommodation works, social distancing works, wearing face masks works, ventilation works, testing people when they have mild symptom works, isolating people and protecting people who are particularly at risk by making sure that they're not exposed. All of these things work, and we should be continuing to do these. Next slide, please. I just wanted to highlight, because I know, you know, obviously this issue will come into its own in the winter, and we don't really know what will be happening in the winter with COVID cases. It depends very much on what variants are circulating. But I think we're still very much of the view that single room accommodation is the safest option with regard to preventing COVID transmission, and that communal style night shelter accommodation in the context of poorly vaccinated populations remains at a high risk. You know, obviously there are things that can be done to mitigate that risk. And I think first and foremost amongst those would be, for example, a fully vaccinated staff and residents in any situation like that. And I think that's going to be hard to achieve, as well as providing separate rooms for clinically vulnerable people, despite whether they've been vaccinated or not, because the vaccine is not perfect, as well as all the other control measures. So, you know, I think if we do go down that route, and I hope we don't, then we would have to have very strict rules to make them safe. And with that, I'll just pass on to the next slide for Al.
Al, just before you start talking, I just want to add one thing to the conversation, which is that this webinar is designed with the London Action and Response in mind. But I know that we'll have people on the webinar who are joining from national and other types of organisations. We're really pleased to have you here, and we hope that you also cascade and use the information that we have for London. There will be some regional differences in the responses as we go through the presentation, but hopefully the guidelines and the guidance, the general sort of key messages are the same. So thank you for joining. Over to you, Al.
Hi, can you hear me?
Yes, Al.
Excellent, thank you. I mean, I've just put this slide up because I think it just absolutely epitomizes that, you know, that people are pretty sick. This is 488 days for an organization not able to welcome back its service users and they have done this morning, and that's their right, that's their choice. They've served a hot breakfast for a number of people. They got a reply pretty soon after saying it's a pretty hot day for a hot breakfast, but never mind. This is Freedom Day, and we're now wandering into some pretty unknown and uncertain territory. This is a graph, and apologies for graphs, but the red bits are, I think you'll know, they follow a certain pattern. On your left, you can see wave one. This is testing across London in the homeless sector. We had a little blip in the middle, just a few outbreaks, and then wham, we got hit with the alpha variant in sort of December, November of last year, and that kept us pretty busy, as you'll all remember. But this is Delta. This is a more transmissible strain. This is a strain that's more likely to put you in hospital if you're not vaccinated. And if you look across these red spikes, I mean, this is what we saw when we had very high levels of attention to detail in terms of IPC. We had a lot of resource in terms of people were in protect accommodation. And we expected, in terms of what hit us over Christmas, we expected cases, despite all our best efforts in IPC, despite all our best efforts in protect. And as you can see on the right-hand side, we're now being hit with Delta. Our data is quite interesting in that it doesn't truly reflect as a lag between when we start to spike in our sector and when the general population take off. And that's mainly attributable to the fact that the early surge is almost invariably the younger age cohorts. And our average age is about 44, 45. But I just want to stress that this is data that was collected from thousands and thousands of people tested, over 10,000 people tested, and it's data that was collected during, great efforts. And we take our hats off to you in terms of the work that's been done to protect this population. Some of the data that we were able to derive from wave 2 over Christmas was actually demonstrating that the infection rate in the emergency and protect accommodation was half of that we were seeing in the general population. And that's just testimony to your huge work and effort. But as Andrew's just highlighted, we're moving into a time of quite extreme uncertainty. We know what works. It's very clear that what we did for the last 18 months has had a dramatic effect in terms of reducing disease and death in the population. But we're now being challenged by two kind of emerging agendas here, and we need to have a clear think about what is going to be our approach. And despite the fact that there's quite a lot of, say, variation in opinion and in some of the guidance, I think it's very important to note that our experts, our SAGE advisors, over a week ago put forward some very clear lines in terms of what we should be doing in our sector. They said, learning from previous waves, we know that there's going to be very high levels of transmission in institutional settings, in settings where people can't choose who they're going to share their airspace with. And that includes homeless shelters with infection seeded back into the community. And they have a very clear line, and one that we will try and hold, which is that all the appropriate controls for the time being will need to be maintained and or enhanced even in these settings. And that's quite clearly necessary, not least because there's a very, very high degree of uncertainty. And that uncertainty, as Andrew clearly said, relates to our scientific knowledge about the effectiveness of the vaccine, our knowledge about the variations, the variants that are emerging, and particularly Delta, and perhaps particularly uncertainty about how we, the general population, are going to respond. Boris said vaccination has severed the link between rising coronavirus cases and deaths, and I I think I'd probably be more aligned with Patrick, who 6 days later said it's not really severed, it's weakened but not broken. Now, Andrew said that vaccination rates have been high in this country, and they have been high in this country, and we are, pretty on the map internationally as far as getting these amazing tools rolled out. But I'm presenting you with a graph here that shows the vaccination uptake in adults over the age of 18, which has been stratified by deprivation indices. And as you can see, there's a very clear slope there, as we see with all health outcomes and many other issues in society. There's a strong correlation between indices of deprivation and vaccine uptake. And the best estimates we can derive from London, if we put them on the graph on the far left-hand side, you'll see our population are not there yet. They're getting there, but they're not there yet. And it seems to be it's perhaps a strange time to abandon vaccination as our way forward and switch to what it could have been interpreted as a policy of herd immunity. Hesitancy. We've heard everything under the sun. We've immunised over 3,000 people in London, and we're going hell for leather to hopefully double that over the coming weeks and months. But we've heard everything, and I'm just going to share this with you because this blew me away. This knocked us sideways. This was said to one of our outreach peers in an emergency hotel in London when he was offered a vaccine. He said, "I don't want a COVID vaccine. I never want COVID to go away. I was on the street for years, and now I've got my own room, my own toilet, and meals every day." This is the lens that this guy looks at life through. This is his exclusion, and he has every right to consider that a vaccine may equate to him losing his accommodation and losing his toilet and losing 3 square meals a day. And many people are extremely concerned about having a vaccine because they fear that that may result in them losing their accommodation. So, not a simple issue, hesitancy. It's complex. Just to sort of throw this out, it's some of the few data we have that are now published that's looking at the effectiveness of any vaccine. That includes any of the licensed vaccines, AZ, Moderna, and Pfizer, predominantly used in the UK. And as you can see, they both all the vaccines continue to confer a very high level of protection against hospitalization, symptomatic disease, etc. But hospitalization especially is pretty much off the map in terms of vaccine performance. This is, as Andrew said earlier, this is a highly effective vaccine by any standards. And 2 doses of either vaccine will provide you with a huge level of protection against disease that's severe enough to require hospitalization. And so I think the data's really becoming quite clear now, and we're seeing some analysis emerging that are starting to talk about, a tale of 2 pandemics, about, data that's splitting hospitalizations and deaths by vaccinated and unvaccinated. And the vaccine's not 100% perfect. We're always going to see a breakthrough in terms of people who are unvaccinated, who received 2 doses, but they're far, 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 far at lower risk of hospitalization and death. This is an amazing scientific advance. The vaccine is quite breathtakingly effective. What's happening in our country now, as we're going to see increasingly, is that this sort of divide. This pandemic has accelerated social inequity across any measurable indices of poverty, disease, and death, loss and bereavement. But it's fundamentally likely to widen inequalities. I'm absolutely pro our efforts to engage with the people that we support, the people that we care for, and engage with the staff teams and continue this conversation because it is working. And we're seeing hundreds and hundreds of people who have shifted from a position of genuine fear and uncertainty to a confident and informed decision to take up the offer of a vaccine. But it takes time. And we're not there. We're not ready to abandon a policy of vaccination for one of herd immunity, not in our population. It's about trust, it's about building trust, and trust takes time. People keep talking about the vaccine wall, but our wall's very clearly not yet built. So as far as a wall of defense is concerned against an aerosolized pathogen, that's not going to be effective. We need to consider, at the heart of it, the rights, human rights. Our walls, hopefully at the moment and for the foreseeable, will extend from the floor to the ceiling, and we will offer people the safety and dignity of their own room, their own accommodation. My room, my rules, my right. I take my hat off to you. We'll get there. Thank you very much.
Thank you, Al. Really helpful context setting, some clear kind of need for urgent action to support this group. And I was just thinking about how, we talk a lot about hospitalization, don't we? But actually, long COVID is a real threat and an issue. And even if you recover from COVID, it's really not a nice virus to have. It's quite nasty. And if we imagine that in some of these settings, both the staff and the residents, if there's an outbreak, might be very unwell, then that can be a very chaotic situation. So the more we can kind of do now to bolster those safeguards and that infection control, the better. So I'm going to now move us straight on to the next speaker. As I said at the start, we've had a number of questions submitted in advance, and we're going to be putting those out with responses following the call. We'll try and take a few of them at the end of this session. But I'm just going to hand over now to Dr. Sarah Kadur, who's joining us from Public Health England, London. And she spent the last few weeks updating infection control guidance for this population and getting it signed off. So a huge thanks to her for all the hard work she's done at pace to get us on a page with some useful advice. So listen closely. Sarah's going to take you through what we should all be doing.
Thanks, Gemma. Firstly, can you see the slides? Wonderful, thank you. Okay, so I'm here today just to give a really brief, rapid overview on the sort of measures that we would recommend to stay in place. A lot of this hopefully will be reminders and refreshers, and the context has been beautifully set by the previous presentation on why we're wanting to carry on with what we're doing. So the London Coronavirus Response Cell, that's the LCRC, it's there based in Public Health England in London to support and manage confirmed cases and outbreaks linked to homeless settings. So if there are concerns, particularly around IPC or compliance, they're there to provide advice and support, and the contact details at the end of the presentation. So they can give, risk assessment advice and outbreak management, and they also liaise with other partners like local authorities and Find and Treat. But it's our opportunity right now to stay vigilant, even as Freedom Day is amongst us. So the QR code there will link you directly to the updated clinically extremely vulnerable guidance. And what that guidance is saying is to still limit contact with people who you would not normally meet by social distancing and ideally meeting outside. But what we're actually saying is advocating for these measures within homeless settings as well, to keep adhering to these measures due to the vulnerability of the population and the high risk settings they're often affiliated to. So Professor Hayward mentioned there on how it spreads. Essentially, transmission is there with contact, droplet and aerosol, and the concern being the Delta variant being particularly more infectious. So what tools do we have to try and break the train of transmission, whichever way that virus is going to transmit? So if we just go back to basics just for a moment, just to alert the audience to, to remember that infectious period can of course start before someone displays symptoms, and that someone actually might be infectious and spreading the virus if they're asymptomatic. And that's where we look at contact tracing, which again I'll talk about in a moment, on sort of deciding who's been a contact from a confirmed or suspected case and who hasn't. But it's important to note, while the vaccine of course is extremely effective and we advocate for that for double dose, someone who's been vaccinated can of course still carry the virus and still transmit it. So it's really important that we carry on with baseline measures, even if someone has been vaccinated. So what I say is it's always important to check guidance. It's always being updated. As we see it now, those who are symptomatic or have been confirmed positive with COVID-19, known as a case, should be isolating for 10 full days. If contacts of that case have been identified, they should still isolate for 10 full days. Even if that contact has a negative test within those 10 days, we would still recommend finishing the isolation period because of that incubation period that the virus still might be harbouring, and they might still be potentially showing symptoms later on into their 10-day period. So isolating is incredibly important. It's still a legal requirement, and it's one of the most effective public health measures to break transmission and prevent further spread. So there's many different types of contacts, and one of the questions there that I noticed was around household contacts. So this generally refers to those living and sleeping in the same household as the case. So in a homeless setting, that might mean sharing a room, sharing a flat, in addition, sharing a kitchen and a bathroom with the confirmed case. But also just to remember cleaners who might have cleaned that setting, even if the case was not present, if the cleaners weren't wearing PPE. But also in that risk assessment, looking at direct contact. So has someone had face-to-face contact? Have they had a conversation for within a minute, or within a metre, apologies, for a minute or longer? Or have they had slightly more extended contact, so 2 metres or more over 15 minutes? And that 15 minutes might be short snap moments throughout the day that collectively add to 15 minutes, or it could be a one prolonged exposure. An interaction through a Perspex screen or equivalent with a COVID positive case, isn't normally considered a contact unless they've had contacts in other scenarios, say, for example, they've had a conversation elsewhere. So regarding self-isolation, so as I've mentioned, household contacts for those who are symptomatic but are not yet confirmed with a test. So if someone's displaying symptoms, they have household contacts, we recommend for those household contacts to isolate. And ideally, they need to isolate in single rooms or as a household with their own bathrooms and facilities. Isolation starts when symptoms begin, or if someone is asymptomatic at the date of test. And then a bit more around testing. So PCR testing is normally done for those who are symptomatic, and the threshold for testing really should be low. So mild symptoms, if you're concerned, it's better to go and try and get a test sooner rather than later, however mild those symptoms might be. We know around 1 in 3 with COVID-19 don't display symptoms, so they're asymptomatic, which means they can spread the virus without knowing it. So testing twice a week increases the chances of detecting COVID-19, and you can do that by using rapid lateral flow testing, or LFD or LFT. That's free for anybody, and it's particularly focused for those who are not fully vaccinated or working or residing in high-risk settings. So they may wish to use rapid testing, particularly in periods where there are risks, such as close contacts in higher risk environments, or you know you're going to spend prolonged time with vulnerable individuals. And those tests can be you can collect them sort of online or via pharmacies, and I know Find and Treat as well are really, really helpful to provide advice around that as well. So some of the key elements of infection control, as you can see on the screen in front of you, I'm going to discuss just briefly then. So the risk of spread is greatest when people are in close contact, particularly in areas where there are poorly ventilated, they're crowded, and contact is prolonged. So advocating, again, social distancing, washing your hands, wearing face coverings, particularly in indoor poorly ventilated places, frequent cleaning of surfaces, and good respiratory hygiene. So that's cough and sneeze hygiene. There were some questions around visitation. So what we'd say is visitors shouldn't be invited into household groups who are isolating, even if it's only one person in that household that is isolating. But it's really important, particularly now that we're trying to reduce the risk of transmission. So ideally, to be safe, minimise social close contact And if you are going to meet outdoors where there is fresh air and avoid enclosed spaces. So social distancing, as I've mentioned, we're concerned around close contact. So the increase in distance is going to decrease the risk of transmission. Assign people to particular bathrooms. So you're trying to reduce as much as you can the sharing of facilities or having strict rotas in place if you're not able to do that. And what we found in some of the learning from LCRC in the outbreaks when I was looking back is that some of these outbreaks were occurring because of staff unable to socially distance or sharing of food and drink. So it's just, again, staying vigilant. We're all tired, you know, sometimes we're all fed up, but just making sure that our behaviours are as vigilant as possible, even if we're relaxing amongst our colleagues. And again, hand hygiene, making sure we're not forgetting the wrists and the forearms, 20 seconds with soap and hot water. And if those facilities aren't available, then to use an alcohol gel containing at least 60 to 70% alcohol and following the same technique as you would hand wash, but allowing your hands to dry as well. Respiratory hygiene, so coughing into the elbow, sneezing or coughing into a tissue, binning it and washing your hand vigorously afterwards as well to prevent further spread and contamination. And then when we look at the general principles around cleaning, reducing clutter can be really, really helpful. Frequent cleaning, so by that it's a minimum of at least twice a day cleaning, one being at the beginning or the end of the day. But frequency should increase depending on the number of people you have in the facility, the flow of the people, and the setup of your own facility, say the amount of communal kitchens, for example, that you have, and really paying extra attention to frequently touched objects. PPE is not normally needed to clean in an area, but we'd obviously recommend washing your hands before and after, and the use of a mask as well. But enhanced cleaning for those who are COVID positive, symptomatic, ideally we would recommend, if possible, for the resident to clean their own room and to provide linen outside the door. Waiting 72 hours to before you go in and clean the room after isolation has ended can be really beneficial because the residual virus would have significantly reduced. And if you are to clean, using disposable cloths or paper roll, and think one side, one wipe in one direction, and avoiding splashes and sprays. If you can't use a detergent, so for example, on a chair that you need to clean, you could consider steam cleaning as well. And then PPE is used in quite limited situations, which I'll discuss in a moment, but essentially that's disposable aprons, gloves, your fluid repellent, surgical masks, and eye protection if you were to need it if you did a risk assessment. But PPE is essentially, as I've mentioned there, in very select circumstances. So, for example, close contact with a symptomatic or positive case. But we're really, advocating the support for staff and residents to wear face coverings in communal areas wherever possible. And then ventilation. So we know the majority of virus transmits within indoor spaces where there's no fresh air and the particles can remain suspended in the air for hours. So actually opening the windows, opening the doors, even for short, sharp bursts for 10 to 15 minutes throughout the day can have a really significant effect. But just as Professor Hayward mentioned there, it's not going to solve the problem. It's not going to prevent spread, for example, in close contact, but it's extremely helpful and useful as an add-on tool to other measures that I've already discussed. And then lastly, vaccination. So we know 2 doses is highly effective against hospitalisation, but even if you're vaccinated, of course, you can still infect others and spread the virus. So, where possible, trying to use communications from organisations such as Groundwell, to really help support residents and staff to take up that offer of the vaccine when they're ready to do so. And then lastly, just to thank my LCRC colleagues who've been inputting into the presentation, and that we've got an FAQ that's been developed by myself and colleague Laura Stoll, which has more details around what I've discussed today and links to guidance as well. And the guidance you can see on the QR code there is to the cleaning of non-healthcare settings outside the home. So I'm conscious of time, so I'll pause there. Thank you.
Thank you very much, Sarah. That was really helpful and clear. I'm going to move us straight on to the next presentation and just mention to everybody that we will likely to go slightly beyond 1:30, but we are recording it. So we'll be sending you the recording if you can't stay for the full webinar. Our colleagues from Mungo's, well done, you've got your presentation up. I'll hand over to you. So Eileen and Stephen, over to you.
Hello. Could someone confirm if you can hear me? Because I had a microphone problem earlier.
I can hear you and I can see the slides.
Could I have the first slide up, please? I'm doing the first two. The first thing that we've done when this next stage, when this opening up today was confirmed as going ahead, was the first thing we did was we issued really clear communication across the organisation saying, stay as you are, continue doing everything you have been doing until we have given other guidance, because we didn't want to be in a position where people felt that they could be following the national guidance and perhaps making changes that we might then want to reverse. We are still in that position, but we are this week starting to finalise where we're going to go in the future, because obviously we recognise that as the wider society is changing, we need to be saying something, because if we're not going to make those changes, we need to explain why we're not making those changes, so we don't have a huge problem with pushback where people are expecting to see them. Throughout this pandemic, we've had COVID secure measures in place, and we have been extremely strict in applying them in all of our accommodation, both the supported accommodation and the hotels, and we have seen minimal numbers of cases of serious illness or deaths and outbreaks. Some of that is probably an element of luck because nobody's brought the infection in, but a lot of that we think is due to the fact that we've had these very strict procedures in place, and we've had them in place from very early on. We know that our population and our client group is particularly vulnerable. We think that they are twice as likely to be categorised as extremely clinically vulnerable or clinically vulnerable. And because of that, we haven't been able to relax at any point. We've had to keep our alert levels high and our enforcement of our COVID secure measures high. We have done a lot of monitoring of this. We've had automated systems where we've required people to upload documents so that we can run reports and we can see things are actually happening. We have looked at our vaccination levels and we have relatively good uptake on vaccine. However, it does remain lower than the national average. We think around 20 points lower on first and second doses, and in some areas it will be lower than that. So we don't see a uniform picture across all of our services, and we know that creates a particular risk for us. We also know with the Delta variant that we're in a period of growth of infections. We're seeing the greater transmissibility and the risk of serious disease in those that are unvaccinated. And our message about staying as we are to staff is really about making sure that we can keep a management of this and that things don't start to slide away from us before we can give new information out to people. All of our staff, our clients, commissioners and public health directors on the whole are saying to us that they are wary of changing too much in this current climate, and that fits with what we're thinking in our various groups that are looking at this issue. Could I get you to move to the next slide, please? Thank you. So what we're planning then at the minute is that we will continue to operate our services that are COVID secure into and going through the winter. And we're conscious of the fact that we need to balance the need to support our clients' recovery. So where we need things in place, we will keep things in place. But if we don't see a good reason for them, then we would consider relaxing those issues. So in particular, the message that we're going to be giving to our staff and to our clients is we need people to maintain enhanced cleaning and hand washing regimes. That's worked really well for us, and we don't want to see any drop off on that. We are maintaining face coverings indoors in our services, in staff client communal spaces, and that is going to include some of our offices, although in some of our offices we will probably relax our requirements on wearing face coverings when people are sitting down. But we're quite keen not to have a big difference between what's going on in services and what's going on in offices, because we don't think that's particularly helpful. We are going to maintain social distancing in our communal spaces and our offices wherever we can. We've spent a lot of time, like many other organisations, setting things up so that we have got these distances in place, and we want to try and continue with those. Our big push is going to be around ventilation, so we are going to be encouraging people to do whatever they can outdoors. And also particularly the point that the last speaker made about, even if you can't keep the window open all of the time, at least open the window periodically so you get some ventilation in. So we will be pushing that. We have a process in place around COVID assessments, and we're going to be maintaining that, and we're going to be maintaining our welfare checking process, which is where we carry out various checks on symptoms and well-being for our clients. Obviously, that's important for the well-being of clients, but it's also really helpful in terms of picking up early if somebody is becoming ill. We are going to make sure that our approach to managing symptomatic and COVID positive cases and outbreaks remains effective. We do a variety of things around that, where we carry out our own checks when we are notified of a case. Particularly, I look at the staff side of things to make sure that we can identify if staff have contracted infection in workplace, and that we can make sure that the relevant people are self-isolating. And all of those processes we will be maintaining for probably the medium term, certainly for the foreseeable future. And also we've moved ahead quite a long way in terms of getting staff to do lateral flow tests wherever possible at home, so that we don't have people coming into the workplace then testing positive and then having to go home again, with the risk obviously that brings for the services, but also the risk for other people that they may encounter on public transport. I'm only doing these slides. My colleague Steve Davis is going to do the next two, so I'll hand over here.
Thanks, Eileen. So this is particularly talking about now, after what we're 14 months into the pandemic, how we keep our staff on board and the residents on board as we go forward. Hearing certainly within services, there's obviously some mission creep now. We've done some great work that's got us these results, but as we all know, sometimes it's difficult to prove that something hasn't happened. So that's the message to our staff, really. Well done. We've done some great work, and all the work that we have done is what's made the difference, and that there's little changed at the moment in the degree of risk. Fundamentally, I think across our services, of course, we have a duty of care. We have a duty of care and safeguarding, and as Andrew explained, that by getting people vaccinated and by taking these measures, we are keeping people out of hospital and fundamentally stopping people dying, which I think I certainly came into this sector as the primary thing to do. I think that's on our hierarchy of needs, the first thing we should be looking at doing. So the measures we have taken have certainly stopped a lot of people going into hospital and certainly stopped a lot of people dying. I think one of the messages now, particularly to staff and to clients, I thought it was rather telling what Sajid Javid in his statement put out around his pre-symptoms or symptoms, even though he was vaccinated, was feeling groggy. Feeling groggy for a lot of the people that we're working alongside is an occupational hazard. We've now got a lot of people who wake up most days feeling groggy, who spend their days feeling groggy. And in the work that I've done, particularly Find and Treat over the years, where we've looked at TB, being a primary crack user, the symptoms were very similar to having TB. I think we could now go through a period of seeing different symptoms and it being masked. And we're going to have to be hyper vigilant to keep an eye on that. One of the things we can do, particularly I think around communicating, is something we've done in the sector, and talking to people here, I'm sure they're aware of PIES. PIES relates to lots of other things other than the physical environment, but we know, I think, the people we're working with respond better to positive messages than negative messages. So people have been told what not to do for a lot of their lives. I think we can think about saying to people so simple messages like, thank you for wearing a mask, rather than you must wear a mask, similar to smoking messages that are out there. I've seen some good ones within the community. There's some very friendly shops and restaurants that have got that message right, that makes you feel like you're doing the right thing, and positive affirmation. As Ian said, we've also got a guidance group. So for other organisations out there, we have a dedicated email address for any concerns from staff and residents, oh, no, particularly for staff, to put through and ask questions on behalf of the people we're working alongside. Next slide, please. So just briefly talking about vaccines. And I'll particularly talk about one of my areas from experience. So I've been doing a lot of work with our services in Ealing. They're quite diverse. It's everything from a hostel to people in scattered accommodation who were placed in TA as part of the pandemic. And the team there has really got stuck into it. Again, I'd say from experience over the years of working with the likes of Find and Treat, what this takes is leadership. It can't just be left to sticking a poster on a wall. I remember a hostel manager years ago called it hostel wallpaper. We tend to stick up a lot of messages and expect people to respond to that. But access to the vaccine, there are multiple options out there. This is universal, and we've seen some great work in Ealing of walk-in centres, pharmacies, staff using the booking systems, working with Find and Treat. We did a barbecue the other day and got nurses on site to vaccinate. And I'll particularly mention member of staff in the borough, Amir. Amir went on the local authority website the other day to try and find where the vaccine centre was. He clicked on the map, a name popped up who was a pharmacist. He directly messaged the pharmacist, and between them were then booking blocks to get 4 or 5 people along at a time to the vaccine centre. We're seeing that the vaccine centres want to do this. They want to reach out to the people that we're working with, and certainly in Ealing at the moment, we're looking at about 65% single vaccine and 45% fully vaccinated. And I'm using the words fully vaccinated for a reason, and that's a message again trying to get across to both the people we work alongside and the staff that until that second shot is there, people aren't fully vaccinated. Around hesitancy, we've got a good system. So when I say I know I've got these numbers we are recording against on client records, I know what we've got. What we're not recording just yet, we will do soon, is hesitancy. Certainly in the Ealing area, we saw early on quite a lot of hesitancy back in February, March, among different populations, but particularly Southeast Asian population. And as Delta began to take hold in India, some of that hesitancy changed. So it's not taking no back in February as someone being hesitant. Equally, I guess we don't want to annoy people. So there's always going to be a few people that are going to be hesitant, but we need to know that we can ask in different ways, different people, and supporting our staff with the right information to be able to challenge some of that. And we've seen that through some effective key working. Peer-to-peer is always good as well, particularly in hostel settings, that if your friends have had it, often they can be quite persuasive. And getting the nurses on site sometimes have been able to persuade people. So the teams in Find and Treat and Groundswell coming around doing the door knocking and being able to directly challenge with that certainly helped. That's it from me.
Great, thank you. So huge amount of information provided already. I'm going to go straight to, and thank you Mungos for showing great kind of action, rapid action and leadership as one of the providers in this space. I hope that many others follow this example of maintaining those IPC measures and not relaxing them as we go into the coming weeks. I'm just going to find our local authority colleague. Here we go. Quick local authority perspective. For anyone on the call who has to leave at past, this is an opportunity for you to do that now, but we are recording this and therefore we'd like to get through all the speakers if possible so that you can kind of watch it and share it with people after the session. Over to you, Vicky and Natasha.
Thank you. I'll say hello, but I'll close the camera because I don't want to freeze, but hello all. So yeah, Vicky and I, we're going to first of all talk about community testing and then go on to discuss what we have been doing in relation to supporting providers. First slide, please. So the main message that we want to get across in relation to testing is that will remain a key component of all the work we are doing and what we will continue to do. This is particularly in recognition that we have the Delta variant. It's more transmissible than the Alpha and obviously the original COVID-19 virus we had before. It's the messaging around continued vigilance and also recognition that 1 in 3 cases are asymptomatic. I'll now hand over to Vicky, who will discuss the work she has been carrying out in relation to testing. Thank you.
Afternoon all. I just want to make a quick point actually. So this is not my normal role. I was obviously seconded into a COVID role, and up until now I've never really come across or dealt with the homeless. So this was my first time of dealing with any kind of supported accommodation or rough sleepers. So any technical questions, I'm probably not your lady, but I will give you my experience from it as well though. So obviously going back to last December was when testing, asymptomatic testing first came into play. So we obviously set a couple of sites up in Westminster, and we also did a couple of pilots in supported accommodation, one of them being a place called Edward Alsop. I'll go back to the asymptomatic testing quickly. So one of our first issues was obviously we set up these, massive testing facilities that anyone could come to. But obviously to register for a test, you need a mobile phone device, you need a home address, you need a mobile number. And that's when we first encountered our problems with rough sleepers, because a lot of them don't have an address, they don't have the mobile technology, so there's digital exclusion there. So we had to set up separate pathways for them. So we managed to get it down to a fine art that anyone that presented themselves as a rough sleeper to any of our sites, they would register using the site address of where they've come from, and we would use probably an outreach worker's mobile telephone number for their result. If not, we would just use the site manager's mobile number. But then also our next problem was, if you test a rough sleeper and then off they go and they don't have any mobile phone or address, if they're positive, then what do? You're searching the streets trying to locate them. So we set up a small kind of area at each site. So if a rough sleeper did present themselves, they would then go into kind of like a holding area. We would give them, tea and coffee, biscuits, which is always good in winter anyway. And once we got their result back, we would then let them know whether it was, negative and positive, and off they would go. Going to Edward Alsop, so we decided to do some mobile testing in Edward Alsop. So we would go to the site itself. This was my first encounter of probably people that have got complex needs, especially drink and drug related. 10 o'clock in the morning, it was the happiest place in the world, honestly. So we arrived and we set up. And when we first did this, not many people were forthcoming of coming to get a COVID test. So then we had to look at incentives. So obviously we then looked at, providing, the chocolate, tea, coffee stuff, but also monetary vouchers that they could go and use in the local supermarket. So then compliance, people were queuing out the doors to come and get a COVID test. Also, what we did was we then also using the homeless health team in Westminster, the nurse practitioners, they also assisted us on site, because some of the problems we encountered with asymptomatic testing is it's a self-test, so you're supposed to swab yourself. And if you've got someone that's high as a kite on spice, or have had 2 bottles of whiskey, swabbing is not the greatest thing for them. So we then looked at a swabbing solution for asymptomatic testing. And then after probably our second or third attempt, the nurse practitioners, we then looked at the clinical SOPs, and we then started doing Hep B testing alongside the COVID testing. So anyone that came for a COVID test, we would offer them a Hep B test as well. So it's like a 2-prong attack really, while we've got them in the room, and that was really successful. And then obviously, lockdown kind of finished, and then we would go into these settings during the day. There wasn't really many people around, so then we had to look at other solutions or making sure they got access to testing. So then we started with the home test kits. So all of our settings now have got access to home test kits. So any of the residents or clients have got access to the home test kits, and that's kind of our main testing source at the moment. In addition to that as well, any clients that have got follow-on accommodation, I think that's the right term, they can contact me and we can book them straight in at any of our test sites. So obviously we don't want them to lose a place or a bed for the evening, so we can get them fast-tracked to get a COVID test. And it's the same thing, we use the outreach workers' details for the results to go back through. Uptake still is, everyone's experience is probably just the same as ours. You get some people that are obviously willing to come forward and carry on to be, continually tested, but there was definitely testing fatigue, especially when the monetary value for like vouchers and incentives dropped out. People just weren't that encouraged to come and do it. So it's still a continuous task to try and get these people tested. But I don't know. We do look at incentives again, but you know, without the incentives, the people they just don't present themselves for it. So it's just something that we're continuously looking at, incentives, and kind of educating them to the reasons why they want to get tested. It follows in with the vaccinations. You know, we've got about a 50-50 uptake in some of these places that want the vaccinations. You know, they've got the same reasoning as, you know, any other person on why they don't want the vaccine. So that's something that we're continually working on as well. Probably about it without me rambling on at the moment.
Great. That's fantastic. Thank you. It's really interesting to hear from Groundswell talking about the peer pressure that might be happening to not be vaccinated in hostels. So they did a quick survey and they showed us that actually there's quite a lot of peer pressure in some of these places. You know, you're a wuss if you have the vaccine or that sort of thing. So I think the more we can all encourage an environment within which it's okay to make a personal choice, but also to think about that kind of community safety angle, the better, and try and counteract some of that peer pressure that might be happening in hostels too.
Sorry, I'll just quickly, so support for providers, we sort of have a multi-pronged approach. So we have monthly provider meetings, which are arranged through our strategic commissioners and pathway managers. At those meetings, we provide an update on government guidance. So, for example, as we progress through the roadmap, we would provide that as a forum to consider what the impact would be on hostels. And that would include mitigation, given that they are high-risk settings. That also provided a forum for question and answers. What has absolutely been key and crucial to the support is the collaboration and our links with our strategic commissioners and pathway managers. They are in direct contact with the hostel providers. They know what's happening on the ground, and any issues that are arising, they will feed that back to public health, and we can see how we can all work together to resolve those issues. For example, in relation to infection control, testing, vaccination uptake. So if it's low, how can we all work together to increase the target? And also if there's any issues in relation to compliance with self-isolation. We also have a standard operating procedure which is updated as the government guidance changes. It has everyone's contact details on there, and it also has information around, for example, prevention. We also have every Wednesday a bi-borough outbreak management team meeting that includes our commissioners, environmental health. We provide a public health update on cases. We share the pattern of what's happening across London. There'll be a conversation around how we're all doing in relation to testing, and then vaccination is a regular discussion we have on the agenda. And in relation to notification of cases, this is something that we will continue to have. So if there is an outbreak or a single case that comes through, the commissioners will notify that on the Microsoft Teams chat, and all of the information provided will enable us to see what support is provided. Do we need to mobilise testing? Has a referral been made to the LCRC? Have Find and Treat been contacted as well? And then finally, we have a strategy in relation to vaccination that's ongoing. Part of that strategy is to look at lessons learned. Do we have to consider other approaches? We consider peer support. We also have the vaccine bus, and that's as well as working with commissioners, partners across both boroughs. We also work with Find and Treat, Groundswell and the CCG, but all of that will continue to be absolutely crucial for us going forward. And the last slide, please. So other considerations for us. So testing for rough sleepers, it has been a challenge, and that will continue to be a challenge, given obviously it's something we need to consider, particularly that given the increase in case numbers that we will be seeing. How can we support rough sleepers to obtain a test and accept the offer of vaccination? How do we continue to support them to isolate? We have had a previous buddy system within the hostels. That's something that we can utilise going forward. We recognise that there is COVID fatigue within, obviously nationally, but within this setting as well, and how can we try and keep up momentum, particularly around encouraging the vaccine. And it's the messaging that, although it's so-called freedom day to day, these settings will continue to be high risk. So how can we carry on to support, and obviously, as everyone has said, to promote the messaging around prevention, infection control, and then also in the future testing capacity as well. Will that continue? Will that become an issue as the case numbers increase? Thank you.
Thanks so much, Natasha. And thank you to everyone who's been listening to all these slides. We're going to do a little bit of Q&A, but I know that people are kind of over time. But I'm just going to sort of just to say one thing, just a big thank you to all our local authority colleagues who have collectively come together and funded testing and surveillance. And thank you to Find and Treat, who've been doing all of that outreach, testing and surveillance. It's an absolute essential plank of our response to this wave. And without it, we wouldn't be able to provide the support that all of these sites need. So just a thank you to all of those people. It's a particular regional thing that we have in London, something that's been very special and really helped us get through these other waves. So thank you very much. So that's the presentations over, and we are going to make them public to you, and we're going to kind of share this recording. But I just wanted to come to a couple of the questions that we've had. Mainly I'm going to come to the ones that have been sort of already submitted kind of prior to our meeting. And so I'm going to turn to kind of panel members now just to answer a few of those if possible. I'm just bringing them up on my own screen. 1 second. Okay, so one of the kind of key questions that we've seen is about sort of the sort of clarity on national policy. And so as we open up as a country, people have got very big concerns about the safeguards of their clients who are not vaccinated. And there's something here about how do you message about the national guidance, that sort of disparity, I guess, between what appears to be kind of the sort of the general guidance for the population and what we're saying today. So how would our members think about conveying that and getting that right balance between you know, what people are hearing in the press and then what we're saying about this population? I'm going to look to panel members to put their hands up if they'd like to try and tackle that question. Okay, Al, over to you.
I mean, I think that's a challenge, not least because some of the national messaging has lacked a bit of clarity and consistency. But I don't think anyone could accuse us of any lack of clarity or consistency. And I think, again, back to, you know, the evidence of what we've achieved during this pandemic to hugely reduce risk of outbreaks and unnecessary suffering and death. We've been extremely successful so far. We've still got clear guidance from MHCLG, which has been updated even today, which absolutely says, following that SAGE recommendation, that we maintain the necessary IPC measures for the foreseeable, given the very high level of uncertainty that's out there. And I think you know, we know what to do. It's quite clear we know what to do because the evidence is writ large. We've achieved so much. So I think we just need to reassure the people that we serve that we know we're not making up as we go along. This is no major deviation from national policy. This is following the best advice, and this is doing the right thing. Thank you.
Thank you, Al. Andrew.
Yes, and I think it's about being very clear that, you know, the risk just hasn't gone away. If anything, it's getting more severe, particularly for the unvaccinated, and you know, and to keep pushing on that vaccination message until we got that full protection from the vaccine, and we're going to really need to maintain these measures.
Great, and I understand we've got some shelter and hostel guidance that's going to come out shortly from Public Health England with some key kind of operating principles. So we might keep an eye out for that as it kind of comes, but we felt that it was really important to have something readied on the 19th in terms of sharing information and guidance. But, you know, there's also this sort of debate about night shelters, isn't there? So a few people have emailed in about that and sort of said, you know, what about the night shelters? You know, what are we going to do in the winter? And just again, for anyone in this call who's thinking about whether or not night shelters should reopen, I'm just wondering what advice you would give them. I'm going to come back to you again, Al, on that one.
Sure. Well, I mean, Andrew put up a very, very clear slide in terms of what the risk is, and what the necessary steps to mitigate that risk is. And it's quite clear at the moment that unvaccinated mass, gatherings of people who are, not a family unit, they are strangers to one another, and they are being asked to sleep in a communal airspace, for hours, is going to result in very, very intense transmission. And we've seen that from data all over the world, from North American data, from European data, attack rates in excess of 60% with significant mortality. The recommendations at the moment to as far as night shelters are concerned are as they stand, I think, are that night shelters are an absolute last resort. They should be something that's considered in extremis, due to extremely severe weather, etc.
Yeah.
But the I don't think that guidance is likely to change. I mean, I fully understand people's need, but I think this goes back to one of the positive legacy effects that we need to try and get out of COVID. The last 18 months almost has been horrific, and we need to get something positive out of this. And one of the positive legacy effects that our colleagues in Scotland have managed to achieve is to change the law so that it is now your right to have your own room. They've got rid of the night shelters, they've opened welcome centres, and that would be, in my mind, a very eminently sensible approach in this country.
And Andrew?
Well, yes, I mean, I would entirely agree with that as ambition. That we've shown the benefits not only for COVID security, but for all sorts of other reasons why having a single room is a much better proposition generally than a night shelter. Now, I appreciate that we don't know what's going to be happening in the winter, and we don't know what provision will be available. I think, as I was suggesting in my slide, then I think it's just about, if you think about a fully vaccinated population and one within a night shelter, and that includes staff and residents, I would say, then that takes a lot of the risk out of it. But I think it's going to be very, very hard to operationalize that. I think people will find it difficult to demonstrate that they have had vaccine. It will also be difficult to make sure that people who are not clinically vulnerable are not within these settings. And I think if vaccine uptake in the staff sector is anything like in the nursing homes, then it's going to be difficult to achieve full vaccination amongst staff as well. So I think there's a lot of practical difficulties to get through if one was to consider a quotes safe night shelter option.
Well, we're going to call the kind of webinar to a close now, but I wanted to kind of tell people just about next steps. Obviously on the screen you can see that it's recorded, and we want you to kind of use it, share it, and we'll be sharing the slides. But what I also wanted to say is that we really have to get the message out there. It's really easy to create these guidelines and advice, and then when you practically try and put them into place, the challenges of doing that in a way that is done in a spirit of good communication and involvement of residents. So we just strongly encourage all the organisations on the line to enter that with a bit of spirit of co-production and get some collective voice within the settings that you're in, because ultimately this is about behaviour change, isn't it? And we can set rules and advice and guidelines, but to really encourage people to take up the vaccine and not listen to peer pressure, to really encourage people to keep each other safe as a community, is going to be really, really important. So use what you've been given, but be out there, and we'd be really interested to hear as well about some of the practical considerations as you try to operationalise it, some of the challenges and barriers that you find. And we're also staying very close to the ground through working with our groundswell colleagues to really kind of hear what this is like over the coming weeks for the people that we're here for today. So just wanted to say a big thank you to our panelists and to all of you for joining, and I hope you get some of this lovely sunny day at some point. Get outside, it's the safest place to be. So thanks everybody, and we'll get this webinar out to you. Take care. Bye.
Thank you.